I'm Jordan Axelrad, co-director of the Inflammatory Bowel Disease Center at NYU Langone Health, and I'm going to be discussing risk stratification in Crohn's disease. Assessing disease activity, severity, and risk stratification in Crohn's disease is essential to guide early and effective therapy, reduce complications, and improve long-term outcomes. Two commonly used systems for assessing disease activity are the Crohn's Disease Activity Index, or the CDAI, and the Harvey-Bradshaw Index, or the HBI. They correlate with each other, but the Crohn's Disease Activity Scoring systems rely on subjective symptoms. In addition to the clinical parameters just mentioned, societies such as the American Gastroenterological Association, or the AGA, recommend stratifying patients into either a low or moderate high risk group for a more complicated disease course, such as the future development of stricturing, penetrating, or perianal disease. By identifying high-risk patients at their Crohn's diagnosis or during disease monitoring, we can tailor treatments to prevent disease progression and optimize care. So today I'll cover three main aspects of risk stratification in Crohn's disease, including clinical and demographic factors, tools for assessment, and then treatment strategies based on risk. So turning to clinical and demographic risk factors, certain patient characteristics are associated with high risk of more complicated disease. Those include age of onset. Early onset disease, such as those less than 30 years of age, are associated with a more severe, aggressive course of Crohn's disease. Pediatric onset Crohn's disease, in particular, carries a very high risk of progression. In terms of disease location and behavior, ileal and ileocolonic involvement are also linked with a higher risk of stricturing and penetrating disease compared to colonic disease in Crohn's. Perianal disease is also a major predictor of complications and often requires early biologic therapy, which we'll be discussing in a bit. Other factors include upper gastrointestinal involvement, such as the duodenum and the stomach, and a large distribution of bowel inflammation. Family history and genetics may also play a role. A strong family history increases the risk of a more severe disease course, although genetics alone do not determine the disease. Certain genes that have been associated with a more severe course include the NOD2 gene, ATG16L1, and IL23R genes. In addition to genetics, smoking has been strongly associated with a more severe disease course, including an increased risk of future surgery and decreased response to our medical therapies. The last really important clinical factor is, of course, a history of having a previous surgery for Crohn's disease. So these are the most important clinical and demographic factors that are important for assessing risk. Turning to how to assess for these, including biomarkers, endoscopy, and radiography, we can use these tools to further risk stratify our patients. Stool and serum biomarkers are critically important for this, and we all have lots of familiarity using C-reactive protein and, of course, fecal calprotectin. Endoscopy can be also used to assess for markers of a more severe disease, including deep ulcers on colonoscopy, the presence of anatomic abnormalities such as strictures, and we often will use the simple endoscopic score for Crohn's disease, or the SES-CD, to quantify disease activity and, of course, measure response to treatment. So we just mentioned biomarkers, endoscopy. Now, what about imaging? So imaging is also a critical aspect of risk stratification. We often use cross-sectional axial imaging, such as MR enterography and CT enterography, to help us detect transmural inflammation and also some of those anatomic complications we were discussing, such as strictures, fistula, and other penetrating complications. Imaging can be also used to assess bowel wall thickening and other complications, including intra-abdominal abscess, which can help indicate a more severe phenotype that requires early medical or surgical intervention. So now that we've discussed the important factors that are associated with the risk stratification and how to measure it, how do we tailor treatment based on this assessment? So treatment should be individualized to prevent disease progression and complications, again, based on how we have stratified our patients into low or moderate high risk, and of course, disease activity based on these tools. So for low risk patients, and to remind everyone, those include patients who have Crohn's with isolated colonic disease, no deep ulcers, low or normal biomarkers, no perianal disease. These are patients, particularly whom have moderate or mild disease activity, who could be considered for more of a step-up approach. An early initiation of advanced therapy would be required for any refractoriness or evidence of progression. For high-risk patients, and again, to review what those include, young age at diagnosis, ileal or ileocolonic disease, deep ulcers on colonoscopy, the presence of perianal disease, high biomarkers, imaging findings demonstrating anatomic abnormalities of severe activities such as stricturing and penetrating disease. These are patients who we need to be very aggressive with early. And these patients should be considered for really top-down therapy. So starting with our most effective therapies for these individual patients. So these will include our biologics, and then for refractoriness, considering small molecules, specifically JAK inhibitors. These are also patients who fit in the high-risk group who could be considered for proactive therapeutic drug monitoring to optimize treatment response when initiating biologic therapies, specifically anti-TNF agents. There are some special considerations here. Folks with perianal disease should really be given anti-TNF therapy early with possible surgical intervention if required. And those with fibrostenotic disease may require endoscopic dilation and or surgery as well early to prevent longer-term complications. So in conclusion, risk stratification in Crohn's disease integrates clinical, biomarker, endoscopic, and radiographic findings to guide personalized treatment. Early identification of high-risk patients allows for timely initiation of effective therapies, helps us reduce complications, and improves long-term outcomes for our patients with Crohn's disease. Thank you.